Hello everyone, welcome back to the ICU training course pharmacotherapy series, the 5th episode. I am Yahan Li, the critical care pharmacist in Wanfang Hospital. Today, we are going to talk about a big issue in the ICU, that is the pharmacokinetic alterations in critical ill patients. Our patients in the daily care of ICU may be different, which is a lot from the general ward patients due to different conditions, due to their critical ill status. But do you know that this status changed may also differ from the medications details as well? And we're going to highly focus about a lot of the pharmacokinetic issues today. So let's begin. Learning objectives are including as following: to understand how critical illness alters the drug PK/PD, pharmacokinetic, pharmacodynamic in the ICU status. Personalized drug regimen for the critically ill based on the drug or patient variables such as medicines, the patient themselves, disease factors, and also an important hot topic, the extracorporeal factors in the life support systems in ICU. Focus on altered the ADME pharmacokinetic issues in ICU, as well as to identify whether CRRT factors or the ECMO factors influencing the drug eliminations. And finally, in our summary, is going to bring you up and framework to apply for dosing strategies in critically ill patients in general. All right, so these may not be familiar with you guys. The 4 main factors or domains in pharmacokinetics can be divided into 4 systems from the A to E. A, in terms of the absorptions, we need to think of a lot of things, like how well these medications get into our patients, right? So in the first known as the quick the pop up things in your mind when we are talking about absorptions need to be bioavailability. And then when the drug enters the body, where will it go? To which organs, which intravascular or extravascular, or which specific organs or target you would like the medications to be functioning at. So that distributions is a lot related about like protein binding, drug factors, or the patient factors themselves. We're going to talk about a bit. And then metabolism in terms of the M. How is the medication now needs to leave the body? How is it broken down in the by the liver enzyme, or it is not really enzyme breakdowns, but just eliminated or directly excrete through the renal systems? How does it live? So when the metabolisms and the excretions or the renal eliminations status will be highly influenced by the liver functions and the renal functions. So when these are altered especially in the critically ill patient, they really have a very high risk to be damaged from the organ failure. So these all need to be in caution. So we're going to break down the specific issues for ICU patients divided into these 4 main categories. I will try to bring them all together with you with a fine framework at the end. What is the patient factors influence the ADME? How is the drug factors themselves in different properties of the ADME? And why is the different disease factors matter in this scenario, and how the extracorporeal these life supporting facility will be different in this issue or the game. So let's first start with the absorption. First, thinking of the absorptions, we would like to, in our dealing with the ICU patients, we need to first think of how is the patient's gastrointestinal motility functions well. Does the patient able to eat, to start the enteral feeding? is the patient's digestion condition has been stable enough to take the oral medication. That is the first thing to think of from the patient side, right? And then other things you might want to know about the medication part, such as the vasopressors themselves can decrease the gut perfusion from its mechanism. And then as well as the H2 receptor blockers like famotidine, cimetidine, etc. This could influence the pH in the gastric systems. So when the medication needs to be absorbed in the acidic pH status environment, then that might be impaired, have a dry interaction. So, such as these, when concurrent use of these H2 receptor blockers, that might decrease the absorptions of these azolate antifungals like ketoconazole or itraconazole as well. And then other factors you might need to check up, as they always, is the drug factors. Also short as the BA, the percentage of bioavailability. Is it 100% absorbed, which means 100 milligram medications orally enter the body systems can be absorbed in the system as a function as 100 milligram. That is the most ideal environment circumstances. However, not every medication has that high enough bioavailability, so it may change your thinking that when I'm dosing the patients and switch from the IV form to the oral form, do I need to change the strength or the dosage? Might be different from this BA issue. All right, then the second part of the pharmacokinetic is the VD, value of distribution. That is a really important thing here. And first thing to remind you guys that actually the volume of distribution is not a real volume in the body. It's not like 100 kilogram patient has 100 liters inside the body system. No. Instead, the volume of distributions is a virtual concept that means medications or the chemicals into the body are starting to excrete to not only intravenous but also to extravenous, such as intracellular or extracellular, etc., to the tissues, to the organs too. So the VD here means the scale that medications excrete and through the body. So the larger the volume, which means the less effective concentrations inside the intravenous systems. All right, so several things would impact the VD, especially in the ICU status. Let's starting about the disease factors. So the VD would increase during sepsis status due to several reasons. First is to because the sepsis status that increased the capillary permeability, such as causing the endothelial damage, the capillary leak from the cells, and then this increase of the sepsis also brings the fluid accumulations into interstitial spaces. All right, and then do all the medication types will be influenced from over be highly related to VD? Luckily, not all of them. Ooh. So most of the medication that will be influenced and should be bring to your cautions in the VD concept is the hydrophilic types medications, such as I listed the antimicrobial here. Here's for you like aminoglycosides, beta-lactams, glycopeptides. They are much more susceptible than the lipophilic agents such as fluoroquinolones. So, as I refresh here, the medication that will be influenced by the VD, you should need to distinguish whether it is the hydrophilic or the lipophilic one. Right. So let's break down into these 4 domains. For the patient factors, what would be related to the volume of distribution concept? Firstly is the body weight, because that still means in a certain way that the VD is largely calculated by the body weight. So the extreme of body weight would impact. And then to a circumstances, if the patient is at the obese status or not, that will impact the lipophilic drugs. Because the obese is not really all of the muscle, the tissues. Instead, there is a large amount of the fat tissues composed of the body compositions in the obesity patients. So these fat would these lipophilic drugs, when enters into an obese patients, would be gathered to the fat part. That is the property. Then the third issue is the critically ill status that would induce an increase of VD specific to the hypophilic drugs. So for the medication part, we need to distinguish whether LISMAD is hydrophilic or lipophilic. And then for the protein binding as well, issue that be related to the free to excrete in the body. And the drug interaction will be play some role as well in the VD. For disease, the most known for one is the sepsis. But other than that, there are also other things to think of, such as the tissue penetrations when we are dealing with an infectious disease. Where is the focus? Where do you want the medications to play the role as the most primary localized part in the body? Is it in the blood system? Is it in the CNS system? Then the medication you choose need to guarantee a good penetration rate into the CNS through the BBB. Whether it's the bone for the penetrations, that is the important thing as well, and as well as the lung, just for some example. And lastly but not least, the extracorporeal systems, such as I listed the ECMO here, that has two main issues that would influence the VD. One is the increase of the fluid volume causing the hemodilution, and the second is the circuit sequestration effect. All right. So I would like to start with the patient factors with some more detail. First, we need to think of the body weight. So whether if the patient is obese or not, it's actually, again, depending on the drug. Not all the medication will be influenced largely by this issue. So for the so if the med is hydrophilic, luckily it has a relatively smaller increase in the VD for hydrophilic drugs in obesity. Just owing to their just very modest increase in blood volume and muscle mass in the obese, rather than just the fat itself as a large portion. But sometimes even in obesity patients, because the proportions of the effective muscle mass decrease or shrinks, it may even decrease the volume of distribution for this hydrophilic med. Then for the lipophilic medications, firstly, in vice versa to the hydrophilic, the lipophilic medications, the volume of distribution is going to increase largely owing to there's a greater distributions into this adipose tissue. So for the obesity patients, we generally define as the BMIs over 30, might require, remember in clinical pro, might require a dose adjustment or the weight-based adjustment. And sometimes with more details, you need to start dig in the literature and think of what is the dose adjustment I should use, because I would like to give the patients as the effective medication that will mostly function in a blood volume, but instead of just to the adipose. And also for the side effect issues, you need to consider a lot. So that's the reasons we would like some medication might require dosing adjustment in these obesity patients. And another thing is which adjustment tool or which adjustment formula should I use? Should I use just adjusted body weight or actual body weight, or other as the ideal body weight is another thing to be considered. So that is up for you to look up. And then after the patient factors, let's look at, this is a really busy map compared to just the ADME for domain, right? So this is pretty much the summary of how critical illness disease status would impact these pharmacokinetic alteration to our ICU patients. So starting from the first top, the most known several disease just you need to be cautious with if your patient is sepsis, severe infection, septic shock, or if your patient is trauma case, or have any burn injury, just received a major surgery. For these several disease issue that would bring to your mind have a surge in the surge will start to emerge in the body systems, and the surge will lead to the vasodilation, and then causing the cardiac output to increase from that, and then generally leading to a capillary leak. And also during this status, the patient may need other helping treatments such as receiving fluid resuscitations, receive vasoactives, and these will all bring to the increase of the value of the distributions to the low, especially for those hydrophilic meds. And these increase would which means leading to a decrease, less optimized drug concentrations for this medication in the systems. And other than that, specifically, there are also other issues that you need to be noticed. First, such as the decrease of the protein binding, and also called as the hypoalbuminemia. And that will bring to increase in the clearance as well for the free-form medication increased. And the other issue may be wondered is the augmented renal clearance, so-called the ARC in short. That means an increase in the renal blood flow, and that will also again lead to an increase in the hydrophilic and end up a decrease of the desired concentrations in the system. And to the right, to our right hand side, just a normal as you can imagine, the organ failure is one of the least favorite clinical outcomes that we would like to really hoping to prevent our patients from getting. But if the patients end up in getting these organ failure, whenever is the liver, is the kidney, or the heart, and they may end up need to put on other extra corporeal circuits such as the CRRT for dialysis or the ECMO for life support. And this failure of the organ would also lead to a decrease for the clearance, right? So, and the hepatic failure would lead to decreased clearance, especially in those lipophilic agents. And so these decreased things, well, may increase the concentrations to a circumstances. And so like sometimes these medication series need to be adjustment to decrease the dose for those whether CHOP B or C class patient. And as for the AKI patients, I believe you all know the definitions of the AKI. It brings to the decrease the clearance in to the hydrophilic agents, and that end up into accumulation or the increased concentration in the body. So that time, so the patient, if the patient is counting on their own residual renal function without other dialysis mode, then you might want to decrease or adjust the the dosage a little bit down, that we call a decreased or renal dosing adjustment. So what does that mean to our patients on treatment successful or the failure? To note that a decreased to the plasma concentration may mean potentially therapy failure, and also the increase for the concentration may sometimes lead to a potential toxicity. All right. So here I would like to provide you some more examples that the take the antimicrobials here and divide it to the hydrophilic or the lipophilic as listed up here for your reference. So we know that hydrophilic antimicrobials often need higher loading dose and increased or decreased maintenance dose in critically ill septic patients in comparison to the non-critical stable patients. On the contrary, similar concentration time profiles are observed for the lipophilic agents in critically ill as well as non-critically ill patients. So luckily, if the patient is on these types of antimicrobials in the ICU, their doses may not be changing that much from the non-critical ill status. That's the same here. For protein binding, we are going to talk about the main category and definition. If you remember the last episode, we were talking about phenytoin. That is one of the unique examples. It belongs to the high protein binding meds. So what is the protein bind or unbound meant to the pharmacological effect? Actually, only those free drugs which is unbound portions can exert the ideal pharmacological effect. So therefore, those patient conditions is that the hypoalbuminemia, whatever from either trauma, from sepsis, or from the lot of the like a trauma patient has the protein loss, or just the cachexia or the malnutrition. Often we refer to below 2.5 as the hypoalbuminemia. Is quite meaningful, especially for those high protein binding agents, because you could imagine there are more free drugs, or the FU fraction of the bound drug is going to increase, and that increase the VD as well, and the volume of distribution increase. It increased the clearance. It also increased the clearance. So, for example, as ertapenem, it is a really high protein binding up to 80 to 95% bound and primarily to the albumin. Other protein binding that is the high affinities here I listed above 70%, such as ticaplanin, daptomycin. Also, the ceftriaxone and ertapenem for your reference for the gram-negative coverage. And other protein alterations, example here that we're going to mention about why these hypoalbuminemia really matters in the real critical ill conditions. First of all, I'm going to show you the stat, but in general, about half of critically ill patients have been once been recorded to have ever have this hypoalbuminemia episode due to several reasons. For the decrease the synthesis of protein during the critical ill or the harmful status of the body, or due to the endogenous binding inhibitors. And the pH change is going to matter as well. And also there are some uremia that causing the substrates that has the conformational binding to those albumin that also altered to leading to these lower hypoalbuminemia status. And so for these free concentrations of the highly protein-bound drugs, that's going to be impact, and such as daptomycin that I just mentioned to you last slide, And two impacts should be remembered. First of all is to increase the effect, because more free concentration is going to emerge. However, it might also increase the risk of toxicity as well for the same reason. And also for clearance, that as the increase of the free concentration, there is also increase for the availability for dialysis removal. So therefore, the protein binding may sometimes even be slightly impacted due to the dialysis regimen. And other than just the albumin anemia, instead of just the sepsis populations, other disease may often should be recalled as one point is that the trauma, the burn patient, the burn injury, or the pregnancy patients due to very special VD status. And next slide, we are talking about the pharmacokinetic, pharmacodynamic issue, which is the drug interaction. Drug interaction is a big topic. We cannot cover every details of drug interaction, so I only here listed the main categories here for you. But just remember, not every drug interactions need to be in caution. It still we need to trace down these a certain interactions, whether that is influence really, which those influence is really documented, has good evidence to be provided. Is the documentation fair enough to be believed, or just a theoretic but not really clinically impact? Anyway, so the main three categories for drug interaction here, the first one is the additive effect. Just two medications can generate together to smooth functions. And the second is a synergistic, or the so-called potentiation effect. That is the one medication when added with another mixture of two or more can produce a greater response than expected, usually greater than the sum of their individual use. And then the third is the other directions, called the antagonism effect. That is, they're going to these two or more drugs, when mixed together, is going to decrease each other's effect to none or less. So why does drug interaction issue specifically matter to the pharmacokinetic? Most of all is metabolism effect. So these pictures, this figure here, as I listed, the CYP450 family of the medications that had a lot to do with each other. From if a certain medication belongs to the CYP450 inducer, then that is going to increase others' clearance. So for like these medications part, and if that medication is the inhibitor, the enzyme inhibitor, by that saying, that is going to decrease this medication is going to be decreased by other or to other, and end up an increased serum concentration. And also there is substrates as well. So these substrates of the CYP3A4 are going to be influenced by the inducer and also to the inhibitor, and generated whether the serum concentration increase or the serum concentration decrease. So it might be difficult to remember all of the pairs of the interaction, but just always to look it up if you are unfamiliar, and then do a final check before you form a formulation or the regimen signed. And then we're going to talk about the other factors mainly influence the metabolisms and also the eliminations by these four categories, four domains. So for the cause these metabolism and eliminations are all belong to excretion. And when we know in patients in the body system, it is the kidney and the liver that that two functions through these two parts. So whether the patient's renal or liver function is impaired, it would be impact to these issues. And we need to not only just the current renal or liver function to be noted, we also need to understanding patient's native renal function before admitted, so we can know the compare and contrast whether the patient is at an acute kidney injury or just the normal baseline or a slightly change from the patient's baseline as the chronic kidney disease status. And then there's another new thing that is called the augmented renal clearance, the ARC, which we're going to talk about in a minute, that is going to impact medication largely. As for the medication-specific issues, we need to understanding the concept of the hepatic extraction ratio, or in short as the EH. And if there's any if the medication is largely metabolized by the liver enzymes, it is that's a metabolism process going to generate any active metabolites. That will be another different story to the pharmacodynamic. For a disease part, we would like to mention again the sepsis and also other disease sites to be remembered. And lastly, but not least, is the ECMO and the CRRT for these both very classic extracorporeal system to work in the body. All right. So for these metabolism and the elimination sections details, I would like to first briefing about the concept of the ARC, the augmented renal clearance. First of all, as you can view from the wording, if the patients have the ARC, but the medication dosage regimen has to do nothing adjustment accordingly, then that ARC status is going to generate a negative impact on treatment failure. The patient, according to the cohort prevalence study, the patient has the ARC that is compared to without ARC that has the significantly higher risk end up with the treatment failure. The definitions of the ARC is when the renal clearance that is COCR here that is above 130. And then what is the risk factors of the patient likely to come out with the ARC status during their critical ill stage? These are the diseases that you should be noted. Whoever is at the trauma, admitted for trauma, for burn injury at relatively younger age, the male or just post-operation is under vasopressor, and that severe illness is all very vague, I know, but these are the all risk factors. So just have to monitor the patient's creatine clearance frequently and be conceptual for the ARC. Also, the estimations of kidney functions matter as well to better understanding this, because you may not want to wait for 24 hours the whole day just waiting for the change for renal clearance. But you can use other calculations such as MDRD, or just by collecting an 8-hour urine collections can also to estimate that for the general renal function. And what is the recommended strategies to compensate this ARC? First, there are several actually. So for your reference, the first you remember to try maximum the dosing during the approved regimen, and And then the second recommend is we can try to prolong or using the continuous infusion to conquer the pharmacodynamic effect if the medication, especially for those antimicrobials, has the time dependent properties. And then if since the most precise method to better monitor the effect of the medications during the ARC status is just to give a blood draw if the laboratory is available to test the therapeutic drug monitoring. So you can precisely adjust the dose concurrently to the concentrations come out. That's the major. The fourth is switch to a less renally eliminated agent. That is makes sense. So this is the prevalence study showing you that according to a Belgian NICU and CQ patients, that how many patients and has the ARC permanently during those all the ICU patients stay. And so here you can see per patient day, there are a total up to 12% permanently express the ARC throughout the whole ICU stay, which is quite a lot. So do not neglect its impact to our patients' treatment failures risk. And then according to the disease status to the metabolism or the eliminations, let's make a focus shift back to our sepsis and septic shock again. During the initial phase of severe sepsis or septic shock, is going to have several impact to the PK parameters at the same times. Any increase to the endothelial and causing the capillary risk is going to have the extravascular fluid shift to the cellular. So that's going to increase the volume of the distribution. And also during this septic shock initial phase, the cardiac output is going to increase, and then also because the possible resuscitation strategy from any fluid or vasopressors given, and also there is an increase in the renal perfusion. Our renal the drugs clearance is going to increase as well. And binding two concepts in go together, that there's a third impact that from the increase to the vascular permeability and also the transcapillary loss of albumin, those the hypoalbuminemia issue that we just mentioned is also able to increase the concentration, increase the clearance and also the volume of this distribution. And these concept all generally causing a decrease of the effective blood concentration. All right, so let's look at that at the RC concept as well. Here I listed as the here I use the sepsis as the example for the ARC conceptual. That's the ARC, just we mentioned, that refers to enhanced excretions of circulating metabolites. And not only that, but also toxins, the waste products, and drugs as compared to baseline as consequence of their GFR during the hyperfiltration. And there is a variety of clinical conditions leading to ARC, including to sepsis here, but also remember others as the trauma, brain injury, even pancreatitis or other autoimmune disorders, ischemia, and major surgeries as well. And oftentimes, these conditions also lead to an increase of the VD, and also thereby providing an additional factor potentially contributing to insufficient concentration. And patients at risk for those subtherapeutic concentrations following ARC are more just luckily becoming more recognized. So hopefully for your institutions as well can notice for this fact. All right. Then the next things we're going to talk about is the drug factors, that is called the hepatic extraction ratio, the EH. The hepatic extraction ratio of drugs, as described in this table on screen, is the fractions of drug cleared after a single pass through the liver. Drugs with a high EH are rapidly cleared by the liver and dependent on hepatic blood flow. Therefore, a positive pressure ventilation or other vasopressors such as epinephrine, adrenaline, and critical illness-induced the liver hypoperfusion may decrease the liver blood flow and increase plasma level of the high EH drugs. Also, to remember, also increase the potential for toxicity as well, especially for those like the propofol and the opioids, other opioids, and including decreased cardiac output and vasodilation have been reported. So, with a reduced of the EH and secondary to advanced heart failure or the septic shock. So here the EH number the below 0.7 is normally recognized, or near 0.7 is considered as a high, and as you can see, mainly as the opioids and propofol here. And as for other common medications, such as for the sedations, as the metabolism, that is considered as the intermediate part. All right, so let's talk about more specific regarding the elimination. First thing to think of is a reduced renal filtration will impact, and the disease related for the sepsis concept as well. To remember, the sepsis not only to causing the capillary leak or the increased cardiac output, but also it generally pathophysiology can impact and alter the end organ disorder. So any sepsis that may alter renal tubular functions, causing the AKI, which is primary pre-renal type, by the way, is all has the impact on the elimination. But luckily, if the sepsis concur and treated well, and then this AKI may be recovered in a short time. Still, not only to the elimination, we also need to consider this dosage need to play other the non-renal metabolism is also playing a small part. So that is the CYP metabolisms, or any like the P glycoproteins for the transporter function. So, and also the dialysis itself has sometimes been reported to somehow can increase this CYP enzymes activity as well. So here I listed to you the common medications from imipenem, meropenem, and vancomycin. Their total eliminations varied between AKI status to the CKD5 chronic kidney disease. And part of the reason is because they showed recover from the sepsis during the AKI, or there is to play a portions in the non-renal metabolisms as well. So if the AKI is going to recover very soon, how could we better predict or better monitors? It's an important thing to remember that we cannot merely dependent or to follow the renal status merely based on the serum creatinine, because there is a poor correlations of serum creatinine with the renal function during the AKI status and also during the renal replacement therapy status. And so, as the alternative, there are some biomarkers that can be used as reference and developed from according to the literature, can maybe temporary for the marker for renal recovery sign, such as an increased concentrations of following plasma inflammatory substance from the interleukins to the macrophage migrations, inhibitory factors, and also the factors in turns for the apoptosis, such as the death receptors 5, the TNF1 and 2. And other biomarkers such as the neutrophil-related lipocalins and the kidney injury molecule and the cell cycle arrest markers as well. All right, so those are the markers. And then we are going to talk about the also very important for the ICU as the weapons to treat and helping the very severe illness patients. But these extracorporeal systems is going to have the impact on the drug's pharmacokinetic as well. So you kind of must know. First, we're going to talk about the ECMO, the extracorporeal membrane oxygenation. So the primary functions of the ECMO is, you can imagine, as we put a cannula on the patient's venous site, and then causing the venous withdrawal from the blood systems, and then this inflow this has all the way go to toward the pump. So these the venous venous blood is the oxygenated ones is drawn into pump by a negative pressure, and then this pump can have the and then shift and drive to this blood to the remove to oxygenator with a positive pressure. So pump is just like the heart, and then oxygenator is just like the lung. So during the oxygenated blood in the oxygenator is going to function as the lung to have the oxygenation and the carboxylation switch. So then after these sections, the blood now is full of the oxygenated blood, and then can go as a venous return back to the body, and then can back to as the arterious or the venous, just depending on whether this ECMO is called as the VV ECMO or VA ECMO. So I'm going to just briefly review the main functions of the ECMO in our ICU indication. It actually has two main roles. The first is as the circulatory support, which means as the heart. So any heart-related dysfunctions can to the end stage can all think of the interferes by the ECMO, such as any cardiac arrest or severe refractory cardiogenic shock, the massive pulmonary embolism, as well as the failure to wean from the cardiopulmonary bypass after the cardio surgery. Then the patient may be temporarily put on the VA ECMO for a short time. And also as a bridge to ventricular assist device to those cardiac or lung transplant, to those cardiac or transplantations surgeries as the potential transplant candidate. And also an ECMO can play the role as the respiratory support to those, again, through with a massive pulmonary embolism, or the patient has the hypoxemic respiratory failure, and that is especially if the PF ratio is really bad, below 70 to 100 milli the Hg, despite an optimized ventilator support. Or the patient has the respiratory failure with hypercapnia leading to the respiratory acidosis, and with a really bad pH level below 7.2. And again, if the patient to a point need lung transplant, then patient will be put on the VV ECMO for a short time as the bridging. So what does the ECMO alter the pharmacokinetic to our topic? There are three main categories that would resulting from the ECMO's impact. First is the ECMO system is going to augment the cardiac output, and also because it enlarge the circuit, and we need to do the blood fill and draw, and then returns back, and with other adding other fluids in, so it's going to requires a larger fluid resuscitations or fluids in the system in the circuit, so it's going to generate the hemodilution. And then the third thing is the drug secretion. That is the ECMO's tubing is going to sequester a certain of medication to the tube, so this effective is going to be impact. So in terms of the pharmacokinetic aspect, an augmented cardiac output means the increase of the clearance, and the hemodilution or the drug sequestrations of the ECMO is going to increase the volume of distributions as well. And these all leading to a final decrease of the blood concentration. So what is the better strategy to increase to do as a response? First, in response to the increase of the volume of distributions in ECMO, some tips I would recommend here to you. First of all is to remember the importance of loading dose. A loading dose can rapidly helping to achieve desired therapeutic concentrations, especially important for those with a long half-life drugs such as for ticagrelor. It has the long half-life to more than 4 days versus very short half-life such as imipenem. And for the other thing to remember, the loading dose should not be adjusted by the current renal function, because the loading dose should not be affected and would not be affected by the renal function. And as a plot here below the slides, that if you want to get the medication in the body and get to the desired target concentration, then the loading dose is going to help you to achieve that targeted concentration goal in a short time compared to just starting from the regular maintenance dose. So this giving a loading dose could be the effective strategies to conquer the ECMO's increased volume of distributions. Remember that. And second things, in terms of the strategy to sequestration and to those ECMO tube, first thing to know what kind of medication is going to be impact, and that is if the medications is either lipophilic or highly protein bound, and these are likely to be sequestrated inside the ECMO circuit. And for with the more details to come for your reference as a lipophilicity, which indicates drug sequestrations to the ECMO tubing. As here you can see that compared to morphine, that is really low, right? Either fentanyl or metabolism or the lorazepam has a relatively higher lipophilicity index. So there's going to causing only, for example, as the metabolism is going to causing only 10 to 30% drugs remain in the systems, and other proportions going to be sequestrated to the ECMO tubing. So that would largely impact the effective concentrations go in the patient's system. So as the strategies to that, one people receiving ECMO may have increased requirement of analgesia and sedation. So keep in mind for that. to come out with a better systematically monitor using the CPOT and the RAS scales would be helpful as well. But do not just directly increase the dose. We still needs any dosing recommendation or modifications must be used in conjunction with clinical judgment with very close patient monitoring, because these analgesia or sedative are both have their downside such as hypertension or respiratory failure. So we still need to be properly monitor the patient and try to give the minimum effective dose. But just remember, the ECMO patient may just need higher dosage compared to patient not on the ECMO because the sequestrations. All right, so here I provide you as an example of our protocol chart in our hospital to dealing with these specific analgesic and sedative medications, and in terms of each PK parameters going to be impact during the ECMO status, and what is the recommendations we need to do during these ECMO period of times. All right, so that is for the ECMO. And then the last main topic we're going to mention today is another important form for the extracorporeal maintenance systems, that is the dialysis. But speaking of the dialysis, there are many factors that would definitely affecting the drum removal, because you can imagine that the dialysis machine is just as the mechanic kidney. But there are many different mode of the dialysis and regimen as well. So starting from the intermittent hemodialysis, actually, currently, many drug dosing guidelines are commonly generated according to the CKD5 patients and not really those critically ill AKI. So do remember, do not just routinely follow what those package inserts said. We still need to distinguish where our patient's conditions is exactly the same as the reference recommended. Otherwise, it's not going to work on our patient because they are in the different status. Does that make sense? So AKI patients compared to those CKD stage 5 have very different PK parameters, as we just mentioned. And critically ill AKI patients often require more frequent intermittent hemodialysis to control their electrolyte and the waste removal. So, for example, if just a regular ESRD patient on the regular intermittent dialysis may often have comes with a frequency as 3 times a week, but to our AKI patients in the initial phase, he or she may require up to on a daily basis for a continuous 3 to even 7 days of a week, due to their also at a status of hypercatabolism. And then the higher intermittent hemodialysis efficiency in the CKD5, because those patients often have the already available AV fistulas for dialysis. So low efficiency compared to our ICU patients who only most likely to only receive a temporary central venous catheter. The dialysis efficiency is going to be impacted due to the higher blood flow in the dialysis circuit. And the other than the intermittent hemodialysis, there are other that we call as a series for CRRT, which means the continuous renal replacement therapy. And it has a lot of different sub-strategies. Here I listed for you from the CAVH list, or the slow continuous ultrafiltrations, or both continuous with the venous to venous, but differ from the hemofiltration or hemodialysis, or combine both as the hemodiafiltration. It's very confusing, I know. Here is the schemas for as an example showing for you. From the left-hand side is the CVVH model, and to the CVVHD or the just absorption. So in those in vitro continuous renal replacement therapy simulations, we need the mainly mechanical kidney, which is the main filtration, the filter, and the CVVH, the continuous hemofiltrations, is with either pre or post filter replacement fluid. And then there is the post pre-filter or the post filter, and has the running the dialysate in and then come out with the effluents, which is a waste from the blood system after dialysis to be removed. And then in the center is the CVVHD, just regular hemodialysis, and then the absorption model to the right. So with a more detail for each different technique, that the CVVH is mainly for can be removed these components of the blood systems by the convection mechanism. However, the CVVHD, the hemodialysis, is mainly using the diffusion. And then if the combined as the both, the hemodialysis filtration is a combined of both diffusion and plus convection. And lastly, the SCUF is not really able to remove any solute, but merely the water is removed. And let's talk about several factors affecting the CRRT. The first thing is the flow. So remember, now the blood flow, now the substrates removed out the body is not only counting on the blood flow anymore, but with these in vitro circuit, the blood rate is now going to composed of both rate of the blood and also the dialysate and also the ultrafiltrate, which is the effluence. And what is the difference between all these? The speed of the fluid removal during hemodialysis, calculated by dividing the total fluid removed by the duration of the session and the patient's post-dialysis weight. So you can see as a higher UFR means faster fluid removal. Instead, a slower of blood or dialysis or the plus the ultrafiltrate rate determines the drug and other solute clearance. And normally in the IHD mode, it is the dialysis rate that has a larger role than just the blood flow rate. And if that is in CRRT, then vice versa. In converse, is the blood flow is going to largely more than just merely the dialysis plus the ultrafiltrate. And importantly, the total clearance of the drug now for the patients receiving CRRT at a critical status is now primarily influenced by the clearance of the CRRT. So if is the medication is going to be able to removed or to filtered by the CRRT is the main thing that drives with the total clearance. Also, some more tips for you. The IV fluid is infused at the replacement fluid rate to replace the ultrafiltrate product. That means the replacement fluid is added if that is for the CVVH that we just see the model. It's normally added either before, so called as a pre-dilution, or after, or so called as a post-dilution, the dial filter. And what means different here is if that is pre-diluted, then the blood entering the filter will be diluted by the infused. And that is going to generate a decrease for the drug concentration in a hemodial filter and generate leading to a decrease to drug removal. But if a CVH has a post-dilution setting, then that means the plasma water can be efficiently convected across the hemodial filter's membranes without too much dilution. So the effluent drug concentrations is relatively high and better reserved this way and removed. So in terms for the drug removal, the part of clearance, the CRRT setting with the replaced filters post dilution is better than pre-dilution setting. But that differs whether the machine itself goes to post or pre-dilution is actually vary by the products and the manufacturers though. All right, then other factors may be affecting as well, such as treatment interruptions. And the reason why the CRRT is oftentimes easily to be interrupted, maybe because of two reasons. First is the in-time dosing modifications corresponding to dialysis plan is vital. Because during this, if the CRRT is indicated to the AKI ICU case, then the treatment plan may be deferred or just canceled anytime if the AKI recover. So this is really highly dependent on the AKI process or the residual renal functions recovery. And also the CRRT may be interrupted or discontinued if the circuit just has a blood clot and failure. And then also there, besides the IHD or CRRT, there is another hybrid in between the both that can take play as a role. So compared to the IHD that oftentimes have the dialysis for a continuous 4 hour only, and CRRT has the continuous run at the whole 24 hours day long. These in between hybrid ones, such as prolonged intermittent renal replacement therapy or SLAT, sustained low efficiency dialysis is kind of to take the advantage of dialysis with a lower efficient but longer time than the IHD. So it may take run as 8 hours per day compared to the whole day long to decrease some burdensome as well to our ICU manpower. So these are different changes may be different to CRRT and the strategy. So what is the clinical considerations for dosing strategies in CRRT specifically? First, to remember the drug removal is impacted by protein binding and the rate of the dialysis flow, not only just the blood flow anymore now. That means that high protein bound drugs will be minimally removed. However, the increased removal comes with the faster flow rates. So in response, at the initial use of certain medications, for example, as antimicrobial, remember the loading dose is important. So loading dose is often required during CRRT for renally eliminated agent. And in patients with renal failure, the time to achievement of steady state is increased, as you can imagine. And also CRRT frequently have an increased volume of distribution. So do remember to start a loading dose to your patient if that is renally eliminated. And then during the CRRT process, while patient is on CRRT, let's keep monitoring the patient's daily residual renal functions to guide the continuous dosing adjustment. If there is any improvement or reductions in the residual renal function, may warrant a change in dosing strategy as well. And last but not least is if the CRRT runs with the problem issues like clotting or just cancel off. So when the CRRT is off, we need to ask, does the patient come to the normal renal function, or the patient is now shift to hemodialysis for a better stable blood pressure, or it still has any residual renal function. So we need to dosing according to the plan afterwards. So this is the chart as example I provide to you that a better understanding with the CRRT or CVVH should be come up with different drug monograph dosing recommendations, not just by the CVVH form itself, but also need to have a different strategy with each different dialysis flow rate. But not for many medications had these modification reference. So far, the literature is still quite sacred. All right. In summary, today we're talk about many variables that can affect drug clearance and volume of distribution during the critical ill status. That whether decrease of the clearance or the increase of the volume of distributions means an increase in the half-life, whereas an increase of the clearance or the decrease of the volume of distributions is going to come out with a shortness of the half-life. And several related factors from the patients to the disease status or to the drug related issues, including as listed here. The for your reference. And then we also talk about several possible solutions for these altered PK/PD status in a critical illness, as responding to the increase of the volume of distribution. Do remember to increase the loading dose if the medication is going to be impact, and if the medication will be impact due to the hypoalbuminemia, especially for those highly protein bound, then do remember to do as the strategy such as increase loading dose or shorter the interval by increasing or increase the daily dose by shorter interval, or try to maximum the pharmacodynamic effect by the continuous or extended infusion, or even more precisely to give a bound or the free-form therapeutic drug monitoring is the most desired option. As for the patient running to the augmenting renal clearance, the ARC status, then as oftentimes it needs to be an increase of the daily dose, and also to shorter the daily the drug interval or extended infusion and the TDM. Last but not least, for the AKI under the CRRT, that we need to dosing based on the CRRT dose, and consider the residual renal functions and doing the TDM. And as well as the for the ECMO sections, can please refer to the previous slides that we emphasize about how to address the VD and also to address the sequestrations to those analgesics and the sedatives as well. So thank you for your attention.